Crohn's disease is a chronic inflammatory disorder of the gastrointestinal tract characterized by a relapsing and remitting course. Evidence suggests that host genetics and microbial dysbiosis have a fundamental role in pathogenesis of Crohn's disease, and childhood is the fastest-growing incident age group. A subgroup of patients with Crohn's disease rapidly progress to complicated disease behaviors with stricturing and/or internal penetrating fistulas. Previous reports about the natural history of this disease have shown rates of complicated disease ranging from 48% to 52% 5 years after diagnosis. Stricturing and penetrating complications account for substantial morbidity and healthcare costs in pediatric onset Crohn's disease. Stricturing occurs when regeneration and repair fail to restore normal tissue architecture, and bowel wall thickening leads to luminal narrowing. Internal penetration develops as a result of active transmural inflammation of the bowel wall with or without distal luminal narrowing. Furthermore, the impact of available therapies, specifically anti-TNF-alpha agents, on the natural history of Crohn's disease remains unclear. Discovery of factors contributing to disease complications and prediction of the risk of such complications in children presenting with non-stricturing and non-penetrating Crohn's disease is crucial to guide therapeutic decisions. In this study, we did a prospective inception cohort study of pediatric patients with newly diagnosed Crohn's disease recruited from 28 sites in the United States and Canada. Between November 1, 2008 and June 30, 2012, we enrolled 913 patients, 78 of whom experienced Crohn's disease complications. Genotypes, antimicrobial serologies, ileal gene expression, and ileal, rectal, and fecal microbiota were assessed. A competing risk model for disease complications was derived and validated in independent groups. The validated competing risk model included age, race, disease location, and antimicrobial serologies, and provided a sensitivity of 66% and specificity of 63%, with a negative predictive value of 95%. Using propensity score matching, we also tested the effect of anti-TNF-alpha therapy exposure within 90 days of diagnosis on complication risk. Patients who received early anti-TNF-alpha therapy were less likely to have penetrating complications, but not stricturing complications, than those who did not receive early anti-TNF-alpha therapy. Ruminococcus was implicated in stricturing complications, and Veillonella in penetrating complications. Ileal genes controlling extracellular matrix production were upregulated at diagnosis, and this gene signature was associated with stricturing in the risk model. When this gene signature was included, the model's specificity improved to 71%. Our findings support the usefulness of risk stratification of pediatric patients with Crohn's disease at diagnosis and selection of anti-TNF-alpha therapy.